release it, tell people more things to release it at home. Again, this is a really cool animation of when the psoas is tight, what it does to the pelvis. And what it does, since you guys know ASPI, is it pulls that side into anterior superior. So when you have the tight muscle, it pulls that side forward. This will all start coming together. Okay. Another key muscle is the psoas muscle that I really look at in the pelvis. Piriformis, yes. It comes off the front of the sacrum and goes out to the top of the hip. And its main job is to externally rotate your foot. So when you kind of put your foot out to the side, that's what it does. A lot of people will just come in and say, I have this pain right here. And it can even cause a sciatica, because in like 20% of the population, the sciatic nerve, which is right here, actually goes through the piriformis muscle. So when that muscle is tight and spasmed, you can actually get a sciatica. And again, I think a lot of women who have sciatica can just have this piriformis syndrome. And what I found in my practice is that a lot of times it's these sacroiliac joints that are moving too much, that are unstable. What do we know with instability, right? If we have something moving too much, the body tries its hardest to brace it. One of the big muscles in the pelvis that braces is this piriformis muscle. So it spasms the piriformis. Why aren't your piriformis spasming on both sides? You know? Usually it's one side, so we know it's an imbalance.
So would it spasm on the same side?
It would spasm on the side of hypermobility.
Okay, so the opposite of the stuck side.
Yes, exactly. It would spasm on the opposite of the stuck side, generally. Now it could be like a hypermobile hip, a knee and ankle. I mean, there's still some other things like, but as a rule, it's spasms on the opposite side of the tighter sacroiliac joint, or it spasms on the same side of the sprained or unstable sacroiliac joint. I think that's for that. So again, there's a lot of other muscles involved in the pelvis, but if you even just have a few in your tool belt, those are the big guys, those two ligaments and these two muscles. And then the glutes you just kind of treat because they're like the entire pelvis. And they're really key too. The quadratus lumborum, the hamstrings, the quads. A lot of times too, what you'll find is the tighter erector spinae are on the side of that instability. I mean, it's just kind of this rule. And when you have something tighter, why is it tight? Our body's so smart. It's trying to stop that motion. So how do we help the body decrease the motion in that joint and let those muscles relax? Okay. How are we doing? Alrighty. So, you'll be able to ask questions later, because after I give my talk, we're going to do a hands-on section. I'm going to show you how to palpate all these things, so it'll be fun. The round ligament of the uterus is something I also address. It goes from the uterus down to the rami, and I think into the labia too, some of its fibers. It's a cool ligament because, unlike most ligaments in the body, it has muscular fibers, because the uterus is muscle, probably. And so it can spasm, and that's why it causes a lot of pain. It's hard to palpate until more like the third trimester in pregnancy. And I'll show you guys my favorite way to palpate it. But there's kind of a funny formula from the chiropractic people, which is like you take the umbilicus and you make an imaginary line out this way, and you take the anterior superior iliac spine, this kind of bump here, and you draw an imaginary line this way, and then you find it. But that always was a little bit challenging for me, so I'll show you the way I like to do it. Then of course there's so many other things, right, that cause pelvic dysfunction, and I'm sure a lot of other people here are going to really nicely address the more visceral ways and the fascial ways and the organ issues in the pelvis that can cause kind of pelvic pain and imbalance. But that's like way more lectures than we have time for. So the Webster technique. Does anyone have any questions at this point?
Yeah, it's really good.
Okay. Yay. All right. So the Webster technique is there's a Dr. Webster, he's a chiropractor, and he came up with this technique to help balance basically the pelvis in order for the uterus to be free from constraints and help the babies get into good position. It's kind of tagged as the way to turn babies, from breech position, and we don't really like to say that, nor is it like good from a malpractice point of view. But what it is good at is balancing the pelvis. So what I tell my patients is, regardless of if we get this baby turned, you're going to have decreased pain and an increased likelihood for a successful birth if we can get your pelvis balanced and moving well. And when I think of pelvic balance too, I'm thinking of like broad scope balance. If your pelvis isn't balanced, I think of that in the broadest way of balancing emotionally, physically, mentally, but through my lens of the biomechanical, physical point of view, because that's what I can work on with my hands. So yeah, this is, and it's taught now by the International Chiropractic Pediatric Association and Dr. Jean Young. She's a really incredible resource. She's on the East Coast, and she does like a Facebook page, and she has a Pathways journal that it's not expensive to subscribe to. It kind of fills the place a lot for Mothering Magazine now that it's not around. It's a pretty nice substitute. It's definitely a little bit more well, I tend to be a little bit more conservative in my approach than it is, but it has a really great article all over this. I really respect her. So, what chiropractors would like to do, and manual therapists throughout time, is to come up with their little cookbook recipe and say everybody should just do it like this. From a biomechanical point of view, Dr. Webster was great in that he came up with this recipe, but as I've been showing you with the pelvis and what happens with certain rotations and stuff, it's kind of like he just put together a lot of pieces that we now know about if you know about AS and PI and what some of these muscles do. So. Again, we're going to demonstrate this in a little bit, but I just wanted to talk you through it before we do. You have the patient lie face down, and you bring the heels to the buttocks. The heel that doesn't go as far in, it becomes, you assume, it's the posterior superior sacrum. Now, that totally makes sense to me because the posterior superior is rotated this way, and that tends to be the side of this tight psoas. Well, if your psoas is tight and this is all rotated, it makes sense that your psoas is kind of pulling in, that your heel's not going to come to the butt as well. Some women, when I'm checking them out, they have absolutely no difference. They're really flexible. And then you get to pelvic, which is really great because, cookbook recipes are nice, but what I say at the end here is like, learn the formula, learn these common restrictions, and remember that none of us are this Leonardo man, right? You get to just use your hands and feel. But according to Dr. Webster, and what I have found for the most part is that more resistant side, you can also kind of pull on the leg, the one that's harder to pull on, tends to be the PS sacrum, which would also be the long leg side. So if you like measuring leg length, that tends to be the longer leg. Again, I don't really do that in my practice for the most part, unless it's really obvious and just jumps out because that's pretty subjective in my point of view. When you're measuring millimeters.
Sorry, the initials are getting a little jumbled difference. So
Yeah.
PS sacrum and AS ilium
Perfect.
would be the restricted leg sacrum.
Exactly.
Right.
Yeah. So, yeah, let me just reiterate that. And that's why I gave you the handout, because this is like a quarter of chiropractic school, right? I mean, a quarter's worth of lecturing. But yeah, so anterior, superior, the illia rolls forward, and the sacrum comes back on that more resistant side.
Those two always go together, is what
Supposedly,
you're saying too.
yeah.
Not always, do sometimes.
Well, I mean, I don't,
Sacrum's kind of fixated, but that ilium's one way or another too.
in general, if things are moving well, that's what once in a while they're totally jammed and you'll find them both moving together and things like that. But in general, that is supposedly the way that they work. So, yeah.
If you were gonna test the ankles to the buttocks
Mhm.
thing, because I refer people for the Webster technique all the time as a
Yeah.
midwife, but
Yeah.
they're usually huge and pregnant, and I'm
Right.
worried about the baby's position at the end.
Yeah, great question. The pregnancy cushion.
Yeah.
So I didn't bring mine because I flew up here from California. But there's this, it's called a pregnancy cushion. It's made in Ashland.
Uh-huh.
and they're like 350,
So you would just do it
375.
on that.
Yeah, and my table also, I have a drop piece that I can raise a little bit, but with the pregnancy cushion, you can put more pillows underneath. And we can pull up the website later to show you guys if anyone's interested. It's a great tool. Moms love laying face down, especially like when they're due any day. They're like, I haven't been able to do this in 9 months, you know?
So just have to.
It has a cutout for the tummy and it has cutouts for the breast. And you could just put it over a massage table, a chiropractic table, anything. They're fantastic. Well worth the money, actually. Yeah, but thank you. I wanted to make sure to mention that. And you know, and that this is one of the purposes of my talk. I mean, I would love for you to refer to chiropractors, but at the same time, I want you to have the tools to know like what to check and things like that in case there isn't somebody available, or if it's, you know, a little bit more minor, if you can catch it sooner. I mean, a lot of times people don't go to chiropractors unless they like barely walk, you know. Except when they're pregnant. Sometimes they're better when they're pregnant because we take care of ourselves a little better when we're thinking we're taking care of somebody else, right? As women. So yeah, that's what, get them on their tummies. It's really the easiest way. After you check that and do the treatment, which I'll then show you while in the hands-on part. Obviously, we're not doing adjusting, but as cranial sacral therapists, we all know that you don't need to adjust. And a lot of times too, with these pregnant women, adjusting can actually be insulting to the tissues because they're already so mobile. So you can do a lot without having to actually adjust. Then with the patient on their back, you bring your hands over the head. This is kind of another trick that Webster figured out, or maybe he stole it from somewhere else. And the side, say, of shorter is the tight psoas side. Again, like that totally makes sense from a biomechanical point of view. If the tight psoas is pulling your hip forward and pulling your whole body down, that's going to be the shorter arm side. But it's a kind of a nice trick, and it's something that, like, cookbooks are nice for a reason. All right. So, history and signs of pelvic instability. It's something everybody's heard, right? The patients will usually say, and there's actually an orthopedic sign for this, when they go and go, it hurts right here. It's called Fortin Fingers test. And it's supposedly an unspecified way to prove that someone has sacroiliac joint dysfunction. But it usually hurts right in the joint itself. And I'm really focusing on the joints again because I'm a chiropractor and we tend to think that joints are the primary issue and then all the muscles and everything adapt to that. So anyway, they say it hurts right here. But usually it will radiate into the buttock, and it also can actually radiate down the thigh, usually in the back. People who get this stuff in the front of the thigh tends to be more of the thoracolumbar junction and that psoas. It's called Main syndrome. There's actually a name for it. So, depending on where people are having their referral, you can kind of, but if it's down the back or on the side, especially the side, if it, a long-term instability can actually really affect the whole side of the leg. So people think they have, different dysfunction there, but it's just kind of that chronic, yeah.
Can it extend all the way down to the foot or mostly?
Yeah. Classically not. But again, with long-term, what I found a lot of times in my practice even is someone will come in with like really intense tailbone pain, but no trauma. I mean, really an instability that's long-term can go all the way down because as we saw from the ligament pictures at the beginning, they're all connected, all those muscles are connected, and when you have a pull on one side, so while at our office we do an internal pubic bone or tailbone move where you can go in and actually adjust it, I always say, let's do a 3-time trial of just really get you balanced first. If we can do that, it takes the pressure off, and then people are usually happy because they usually don't really want the internal move. So, it also tends to be increased pain with stairs, hills, anything that goes up and down, walking, everything that you think should make you feel better, right? Yoga, stretching, walking, unless it's like flat, it can really aggravate a pretty good instability or sprain. Prolonged sitting can aggravate it because prolonged sitting flares the sacroiliac joints. Menstruation, of course, because you get the hormonal issues. People describe not only this pain here, but they also usually have like a catch or they feel like it's going to go out. There's some sort of instability. Like I had one patient recently say, I'm afraid to relax because the pain comes when I relax, which makes sense, right? The joint opens up when you relax. The history is body work helps temporarily chiropractic adjusting, but usually within a day or two they go out again. Sometimes even that day, you know, it helps for a few hours. These kind of people love craniosacral work because they're so usually unstable that anywhere they go, even a massage can hurt them. And again, that's kind of severe. There's a broad spectrum of things, but it can be, yeah. Let's see, anything else in here? Oh, so, okay, so another way I like to look at as outcome markers is when you first, and when I say palpate here, it's like palpate with an elbow, right? When you first palpate these landmarks in the pelvis, they feel bruised and really tender. To me, that's showing me that this is a long-term issue. It's chronic, there's quite a bit of inflammation. So one of the things I tell my patients is, one of the outcome markers we use is when I palpate these, when I push on these in the future, we want it to get to the point where it's, oh, that hurts so good. You know, like that kind of massage. We don't want this like, oh my gosh, that feels bruised, which is a majority of these people will have that. And then there are lots of there's like 5 orthopedic tests that show this, and if you ever want to search, they're online. But you don't really need that probably unless you're a chiropractor or physical therapist or something. So my treatment options. I like to balance the pelvis as best as possible. I do that through the Webster technique, soft tissue therapy, craniosacral, myofascial release, and chiropractic adjusting. I also have them brace if it's really bad. So these have become like my favorite thing in the world. That's why I gave you the handout on them. They're made by a chiropractor in Portland, or in the Midwest, Dr. Stroll, and he's a man, but he figured this out, so that's exciting. I'd love to meet him one day. They are, this is not my size, but I'll show you. You put them on like this, I'm going to put it on, but you put it on over, I mean, again, most women who have this, like, will say, this is where it hurts. So you get, okay, and it's also where you get the little dimples. That's right over the sacroiliac joint if you're lucky to have the dimples of Venus or whatever they're called. So you put them on over the dimples. And then you tighten them down. Now, in a severe strain situation, which I actually had in chiropractic school due to a bad move, you wear this for 6 weeks, 24 hours a day. I haven't had to do that with hardly any of my patients except like 2. One was a big yogi. Yoga, especially Bikram, is really hard on the sacroiliac joints, and people who love Bikram tend to be really unstable because it's the only thing that stretches their joints, right? It's the only thing that gets deep into them. So, I tell them, okay, if you have to do Bikram, that's fine, but wear your brace, you know, at least support these sacroiliac joints. What happens with the brace is that, we're okay on time, right? Yeah, we're not, okay, yeah, we're good. I have to 12:30? 12:50. Oh, that's great.
And I didn't know for sure.
And that clock's right? That clock's right?
Yes.
Okay, perfect.
So even with sleep.
Yes.
You have till 12:30, Heather.
Okay, perfect.
Yeah.
Yeah, even with sleep. Yeah.
Do you find it superior to like kinesio tape?
Yes, definitely. What this brace does is it takes the work. See, I put it on right now. I'm like, ah. And I actually brought a whole bag of them because I figure there's going to be a certain amount, like quite a few women, especially if you do heavier duty body work. You know, like sometimes I'll just wear this the week before I get my period, or you know, like now I don't need it all the time, but I wear it when I feel unstable. If I know I'm going to go on a hike that when I'm already I'm a little unstable, you know, okay. What it does is it basically takes the job of the ligaments. So when a joint moves too much, you strain the ligaments. So I describe it to my patients like, okay, you sprain your ankle, right? If you don't brace your ankle and it stays strained, you're going to be walking on a turned ankle all the time because those ligaments are damaged. And unless you kind of support them, get off them, put a brace around it or something, they're going to just stay chronically stretched. And what we know from a nervous system perspective is like the little proprioceptive nervous system, which is what tells our body where it is in space, that gets damaged and sprains. So you can do all the therapy you want on a muscle, and especially, you know, those glutes over the sacroiliac joint and stuff, but unless you kind of retrain the nervous system and the proprioceptive nervous system in particular to the ligaments, it's gonna be a temporary fix. So, and even this, you know, when you have an instability too, it can be, you know, as women with our hormones and just life in general, it's hard to absolutely cure somebody of this instability, but you give them a lot of tools that they can deal with it and it doesn't cause pain. You just, you know, you can preemptively treat yourself before it becomes painful. So anyway, these like take the job of the ligaments and ligaments take about 6 to 8 weeks to heal. So you just tell someone, think about running this for 6 to 8 weeks. I've had plenty of women, in particular women who are on their first or third pregnancies, you know, where this pregnant, and some women say I actually can't, it really presses on the belly too much, and some women just run when they're taking walks, which is what I recommend, or when they're active, if they have a toddler, they're lifting. Because when you sit with a pregnant belly in particular, this is not comfortable. But it's a great tool for pregnancy and then also right after you give birth, because if you're prone to any sort of instability, you have this like 6-week window to really reshape your pelvis, right? Because all your ligaments are gonna be maximally stretched. You're gonna have tons of relaxin in your system and all these other hormones. So if you have an imbalance and you can really get to it those first 6 weeks, which most of us writers do them for babies the first 6 weeks. So it's, but if I try to give my patients tools before, so if I know they're really unstable before they give birth, they say this, just, you know, if you hurt it all after you give birth, wear the brace. It's a really great tool. Yeah.
Can you comment, or maybe you're gonna get into this, on the, how an epidural would iatrogenically create an instability?
Oh, that's an interesting one. You know, I don't know the function of the epidural on instability, but what I mean, we know it affects the dural tube and headaches and all that, so I would just assume that it would be from an inflammation point of view. That would be a really great research topic.
Well,
But-
in terms of how it acts on the pelvic floor, relaxing it, because,
Right.
you know, the baby's cardinal movements are disturbed.
Yeah, and so again, anytime we have relaxation, we're gonna get the instability increased. And then also, it's creating inflammation, which I haven't mentioned yet, but inflammation actually comes before spasm, right? So when we have something that's moving too much, we get inflammation. And look, I mean, people now know how bad inflammation is for our bodies, but I can tell, so to answer your question, you know, how epidurals could affect this, you know, I would, the loosening, like you said, and then the inflammation aspect. And the inflammation, again, is just a sign that there's too much movement, something's wrong. And those little cells will share, they'll start local, and then they'll get more and more and more, and before you know it, your whole pelvis hurts, or your whole side down to your tailbone hurts, within weeks, yeah?
Are you saying inflammation just from the standpoint of having a needle stuck through tissue?
Yeah.
Causing, okay.
Yeah,
Just wanted to clarify.
it's just an insult to the body.
Yeah.
Just a follow-on question, I was just mulling over that benefit of releasing the tight muscles to get balance, but then you're also releasing more
Yeah.
of the stability. So
Exactly.
Can you talk about that a little bit?
Well, that's why I
It's
like,
out of the both ends.
it's totally, yeah, you're totally true,
Is
and this is why it's
the
tricky.
instability really benefiting from strengthening like Pilates or any of the
Well,
other things?
Okay, so that's a great question. You know, so what she's asking about is, if you have an instability and it's tightened and you release it, are you just furthering the instability? And then would you do something like Pilates?
I get it from the
Yeah.
sense of balance on
Yeah.
the sides of the
Yeah,
pelvis
and that's,
getting that
you know, this is
even,
why
but it's
I
just
love
like
working
things
with,
up, too.
yeah, totally. And this is why I love working with women, because, I mean, don't we feel like this is our life anyway? You know, we're juggling all these balls, and it's like, okay, we're gonna release this because it's tight, but that's actually just, you know, another ball in the air because, yeah, totally. You are, in a way, adding to the instability, but you're balancing. And that's the key. We need to have the balance on, you know, physical, every level, right? So if we're moving too much, fine, let's move too much, but let's move too much all equally in every joint, because then we won't have pain. You know, what causes pain is the imbalance. So, and that's why you can have lots of women at the end of pregnancy with no pain. They just don't have an instability. I mean, they don't have an imbalance. But if you have like, well, again, a little bit tighter on the right, or say, oh, this psoas is spasm on the right, or whatever, that's when you start, you know, everything changes and adapts to that tight area. And that's what we're trying to
So
correct.
with the instability, really your goal is to find the best balance you can in the
Exactly.
pelvis.
Yeah, yeah.
And strengthen from there, move
Yeah,
from there.
all these
flexible
variables
from
that are
there.
completely out of our control and like fluctuating all the time, which again, I mean, to me, that's life, right? So I love it. So yeah, and as far as exercise afterwards, that's a great question. Tammy Kent, who's speaking here later, had a really, she told me initially, like, I don't want my women to do Kegels until I get their internal muscles balanced, because otherwise you're gonna strengthen what's already strong and ignore what's inhibited and what's weak, right? So, I don't know if she still says that, but that's what she told me after I had my first baby. So, that's the same in the pelvis, and that's why I'm pretty tentative to recommend Pilates or even yoga, stuff like that, unless it's pretty mild for the first part of really dealing with an instability, because you gotta fix the balance and the neurology to the area first and turn on those muscles that aren't working and, get the spasm out of the things that are already too tight, because otherwise you're just gonna strengthen what's strong and ignore what's inhibited, so.
I'm gonna ask one more thing.
Yeah.
And I don't know the term of this, but when the belly splits a
Oh,
little bit.
diastasis recti?
Diastasis, thank you.
Yeah, oh my gosh, huge for
Postpartum.
pelvic instability. There's, I like what Carol's reference on that Lose Your Mummy Tummy, which is an awful name, but that's a book and she has a video. For at least strengthening, beginning to strengthen with that. When that happens, you're set back even a few more steps for the
Is
instability.
it pretty common for
Yeah.
most people to have?
And what you read is like it happens in women who are overweight and out of shape. Well, I think it happens in women who are in shape.
I have it.
Yeah, I know, I still have it from my two births too.